Hello, my name is Leo. I'm an intensive care doctor working in the UK. Hope you're well. In this video, I'd like to discuss when to admit a patient to an intensive care unit. We always recommend early referral to ICU if there is any concern with the patient. If referral is delayed until it's too late, the patient's life will be at risk and the chances of full recovery are quite slim. So, if we feel like a patient is appropriate for ICU admission, we should discuss with the senior team member to facilitate early admission to ICU. To admit a patient to ICU, first of all, we should consider the research status of the patient. In the UK, we use TAP, Treatment Escalation Plan Form, or RESPECT, Recommended Summary Plan for Emergency Care and Treatment form. Sometimes, it could be quite tricky to diagnose the patient in the first instance, and we should just focus on the organ support. However, whenever possible, we should also consider what is the working diagnosis of the patient, severity, and prognosis of the disease. Also, the patient's response to the treatment that we're currently giving or going to give. Next, it's essential to consider the comorbidities of the patient, such as past medical history, patient's baseline, and background physical status, recently before this admission, to assess the clinical frailty. Then, we could anticipate the likely outcome of the disease and the intensive treatment that we're going to give on ICU. It is also very important to consider the expected quality of life of the patient after ICU discharge. Will the patient go back to independence? Will the patient need package of care at home? Or will the patient need nursing home? Last but not least, we need to take patients' and relatives' wishes in consideration. We should address if the patient has any advance directives or lasting power of attorney. If the patient does, we are obliged to respect the wishes if the patient does not want any intensive care treatment. We need to bear in mind that age alone is no contraindication to ICU admission. We should consider to admit the patient to intensive care unit if the patient is fit and well despite old age. On the other hand, if a patient is too frail for young age, ICU admission may not be appropriate. If we're not sure about the patient's background, we should give benefit of doubt to the patient, aim for full escalation, and gather further information from next of kin and family. In summary, if the illness is a reversible condition, if there is potential or established single or multi-organ failure, if patient can benefit from more detailed observation, and invasive treatment, if the patient could be safer on ICU than on general wards, then we should consider referring the patient to intensive care unit. So, what can we do if a patient is admitted to ICU? We can provide advanced respiratory support to patients with, for example, severe pulmonary pathology such as life-threatening asthma or severe pulmonary hemorrhage, cardiac arrest, major trauma, facial burns, or severe drug overdose. It could be invasive like endotracheal intubation and mechanical ventilation, or non-invasive ventilation like CPAP. We can also support cardiovascularly with vasopressors or inotropes and monitor blood pressure with arterial line in patients with, for example, hypovolemia, sepsis, which is not responsive to fluid, severe heart failure, for instance, severe pulmonary hypertension or myocardial infarct, and post-surgical patients. Neurologically, if the patient has too low GCS to maintain airway reflex, or patient with severe agitation, like in patients with severe CNS infections, status epilepticus, and drug overdose, we can intubate the patient to protect the airway and sedate the patient until the clinical situations improve. We can also do invasive monitoring like ICP monitoring and neuroprognostication in patients with catastrophic head injury or intracranial bleed, even if the prognosis is poor. In this scenario, the main reason for ICU admission is for neuroprotective measures and support other organs to give the patient the best possible chance to survive, and also consider potential organ donation after discussing with specialist nurse and family. From renal point of view, we can commence renal replacement therapy in patients with AKI with or without CKD if they are anuric with features of fluid overload like flash pulmonary edema, severe hyperkalemia and metabolic acidosis not responsive to medical treatment, and uremic pericarditis or encephalopathy. On our ICU, we use continuous veno-venous hemodialysis. We can also consider renal replacement therapy in patients with severe drug overdose if appropriate. Sometimes we can admit a patient to intensive care unit or high dependency unit to replace electrolytes, for example potassium, via central IV access if peripheral replacement is not adequate. In this case, we can insert the central line and replace electrolytes more efficiently under close monitoring of the vital signs. These are common reasons for ICU admission. Hope this video is useful to you. If it is, please share it with your friends and colleagues. I'll see you in the next video. Take care.